Hello, and welcome to another edition of This Week in Hearing. I'm Brian Taylor, and our topic this week is hearing loss and cognition. What does the research tell us? And here today to discuss this important topic is Danielle Powell. Danielle is both an audiologist and an epidemiologist at Johns Hopkins University School of Public Health. Dr. Powell, I want to welcome you to This Week in Hearing.
Thank you for having me.
And before we dive into the topic, I just want to let our audience know that what piqued my interest in this was a couple of things, actually. I saw you and your team had an outstanding podium session at the February American Auditory Society meeting. And then around that same time, I read a paper that you published in, I think it was Frontiers of Aging Neuroscience. Not exactly something that rolls off the tip of the tongue of an audiologist, but it's a really, I thought it was an excellent kind of overview of research, the direction we need to go. And anyway, before we dive into that, I thought if you could maybe share a little bit about your background and what has interested you in this topic of, combining hearing loss and cognition.
Sure. Yeah, absolutely. So my background as an audiologist actually started with more direct training in pediatrics. I was on some various traineeships during my AED program, and then did my clinical externships at a children's hospital. So I've kind of found my way into focusing on older adults and hearing. Some of my first jobs out of school was working with primarily older adults in a city-based setting, so kind of a broad range of a patient population, which was really informative. It kind of led me towards the path that I've currently ended up on. I was getting patients from across income levels, from across education backgrounds, and I was starting to get questions from my patients and them thinking about, well, how does hearing loss affect me as I'm aging, as I'm getting older, both as a professional, as I retire, different things that they were considering, and realizing that we don't know as much about what hearing loss and how it impacts aging. We know a lot about it in kids, but the strength of the research that we know in the older adult isn't quite as much there. And I was working at a time when a lot of the research on hearing loss and cognition and dementia was really picking up steam and getting picked up by mainstream media and news outlets as well. And so my patients were coming in with these questions. And all of this kind of led me thinking about, hearing loss from a broader approach, a life course perspective, so to speak. And what does that mean for us as we age, and what can we do about it? And that's what kind of led me towards the research that I am now. Part of it was the research group that I was able to join at Johns Hopkins. This was one of the primary areas of research that they were focused on. But it really tied in nicely to some of my own areas that I was kind of developing just from this anecdotal experience as well.
I see. Well, I think like a lot of clinicians out there, I have what I think is kind of a cursory knowledge of the relationship between hearing loss and cognition. But one of the things I really liked about this recent article that I cited was that I thought you reviewed quite nicely some of the more recent findings that talk about this linkage. So maybe if you could get our colleagues out there in the clinical world up to speed on some of the current findings that talk about this linkage between hearing loss and cognition.
Yeah, absolutely. So one of the things that I referenced a lot in that paper that really does the best job that we have so far in summarizing the strong evidence that we have was done by a large commission from The Lancet, which is a very well-known, highly reputable kind of health-related journal that had a commission both in 2017 and in 2020. They updated their report on dementia prevention, intervention, and care. And in 2020, they kind of really highlighted 12 identifiable risk factors for dementia that we could potentially modify, meaning that we could maybe do something about to where we could potentially delay or prevent cases of dementia. And most specifically and interesting is that hearing loss was one of those 12 risk factors identified that also potentially has the largest potential for prevention of dementia cases. They estimated that maybe up to about 9% of dementia cases could be prevented by intervening on hearing loss. And in summary with that, part of the strength of the evidence that we have has been the growing number of research studies that are supporting this association. Now, what's been changing more recently is that we're getting larger research studies. We're getting a better understanding across a broader population of the strength of association. And what we know so far is that has kind of led to 3 to 4 different kind of theories of why do we see, why are individuals with hearing loss at a greater risk for either cognitive decline or dementia. And there's some theories kind of driving that. So some of you might be familiar with this, but it's important when we think about, what do we do about hearing loss that might lead to dementia prevention, for example. One of these theories is that there might be something that we call a common cause, which that leads to both hearing loss and dementia. This could be something like neurodegeneration in the brain, like vascular related factors that can impact both, or maybe a genetic related component that can impact both. There's a lot of kind of emerging research about the genetic aspect specifically that we still just don't really understand. There's also this idea of that we call, some people have called the social deprivation, for example. I'm sorry, sensory deprivation, for example. And this idea that more recent lab-based medical imaging has really kind of helped support is that with prolonged sensory deprivation or of auditory deprivations in particular in the brain can lead to changes in brain structure and function, decreased synapses, that sort of thing that can really impact the already existing dementia-related pathology that's existing in the brain and kind of lead to this presentation of cognitive changes or dementia symptoms. That's more of a direct, permanent change to the brain. Additionally, there's more of kind of an indirect, maybe we could actually do something about these changes thought process that leads to the idea that this impaired speech signal that's going up to the brain, difficulty with speech and noise, taxes the cognitive processing and ability that we already have. An idea that is commonly called your cognitive, it's like leads to takes into account what we call your cognitive load. I'm trying not to throw a lot of jargon out there, but sometimes I trip myself up, as you can guess. Okay. So your brains and your cognitive processing's ability to kind of compensate for changes in cognition, that pathology that might already be there. When you have a hard time and need to focus a lot more in challenging listening environments, for example, that takes away from that cognitive processing and ability. Another thing that we're starting to, the evidence is a little bit more mixed, but we're seeing kind of this continual connection and association in studies is that that of social isolation or decreased social engagement. We all know that with hearing loss, an individual can become more isolated, withdraw from that social engagement and interactions with others. But that type of interaction and engagement can really be protective against cognitive changes or dementia. And so there's kind of these overarching theories of why might we be seeing this greater association between the two. Most likely, more than one of these are at play. It could be all of them. We don't really know. And that's what a lot of this research is really starting to try to tease out a little bit more. What's really starting to change more recently is the strength of the research that we have. So there are some, a lot of these studies are based on what we call observational data. So it's where we're taking a group of people in public health and epidemiology that's a population-based level, so not at an individual level. And we're trying to make an understanding of, I have a given exposure, hearing loss, for example. I want to understand, are you at a greater risk? Are you more likely to develop dementia? We can't necessarily control for all of these other factors. We can't give someone hearing loss. We can't give someone a hearing aid necessarily. That type of strong evidence comes from a clinical trial. And there's a lot of those with longer standing studies where we have a lot more control of the environment that's happening that can give us the best understanding. Specifically, I'm wondering about, hearing aid use as an intervention for dementia or cognition later on. Yeah, that's
good.
That.
And we'll talk maybe a little more about hearing aids in a minute, but I think your explanation of those different theories, I think, makes it much easier to see this linkage between hearing loss and cognitive function.
The other thing I want to point out is a lot of those are thinking about hearing loss in the sense of peripheral hearing loss. And there's a reason why there's so much more evidence related to that too, is because when we're thinking about, central auditory performance, central auditory function, that is very much dependent on your cognitive abilities and cognitive processing. And so it can become very hard to tease out these differences of what contributes to where. But it's really interesting when you think about, what does that mean, big picture on how someone functions. So the evidence that we have right now is on peripheral hearing. It's easier to isolate that independent effect of hearing on cognition. there's more interest kind of growing on this central auditory function ability and what that might mean for what we think about cognition and dementia too. But it's messy, and there's a lot to kind of tease out still with that.
Given how the central auditory system works, I can see how that would be really tough to tease that out.
Yeah, absolutely.
So one thing I'm really curious about, and I think a lot of our viewers would be too, because I think they see it's not this relationship's been talked about in our profession for at least a decade.
Yeah.
And I think the challenge, and maybe this is just me talking, but I think other people share this sentiment, and that is, how do you talk about these things, this linkage with your patients? Like, how would you talk about it? I'm guessing there's probably a difference in how you might talk about this with somebody who's maybe 60 versus somebody who's 90 years old. So can you maybe share some insights with our viewers on how you would talk about this linkage in a way that's understandable and relatable to patients?
Yeah, no, absolutely. Some of the things would be the same, depending on the age. Other things obviously would be different. And some of it would also depend on, the future research, and hopefully teasing out, what pathway are we talking about that relates to this association, because that would matter too. Mm-hmm. What we want to be careful about saying is, it's not accurate to say you have hearing loss, you're going to get dementia. That's what's not accurate. We want to be clear with our patients so that we don't, be alarmist or something like that. What we can say so far is that, based on the studies and the data that we have, on average, what we're seeing is individuals with hearing loss are at a greater risk or potentially more likely to develop dementia later. But that's thinking at about a bigger picture level. We don't want to take that information and put it on an individual. What our information does allow us to do is allow providers, primary care providers, to try to have an understanding of those who might be at a greater risk of developing dementia later, and therefore think about ways that we can maybe mitigate that risk. So that's my big picture caveat of how we talk about it with patients. You're at a greater risk. It doesn't mean you're necessarily going to get dementia, but maybe these are some things that we can do to potentially mitigate the risk that your hearing might present. Now, that being said, there's a lot of studies showing hearing aids. Hopefully the strength of those studies, again, is going to be supported even further in the coming year or two with the clinical trial evidence that will be out. Cochlear implants, too. We're seeing some emerging studies. They're still limited, but that are supporting improvements for dementia patients with cochlear implantation as well. For some of your younger adults with hearing loss, there's a lot of things that you can talk about. One is simply, actually for any age, hearing and dementia is one thing, but we also are seeing more and more evidence to support that treating or managing hearing loss has a broad impact on your quality of life, not just with cognition, but with depression, with isolation, with falls. There's a lot of different things that your hearing can impact. And one of my primary goals is to help other people, both patients and other professions, other healthcare professions, kind of understand that. So for your younger patient, for example, one of the biggest things is treating if they have hearing loss, understanding that the earlier that you do something about it, the better. We say this all the time to our patients, but where there's more and more evidence to show, especially with some of those pathways that I talked about, prolonged sensory deprivation can lead to changes in the brain structure and function. That's something that once that happens, we can't necessarily do anything about. Alternatively, the other pathway that I talked about, where it's this increased cognitive load, this taking away of your cognitive resources that you have to kind of support you in other areas, that could be beneficial at any age, whether you're a younger adult in a working profession or you're an older adult who's already demonstrating some changes in cognition. Making it easier for you to hear allows for more of that cognitive processing in the general environment. Same thing with social isolation and that kind of thing. That can help at any age. What we are seeing that I think a lot of providers and even patients, and particularly caregivers, is important to know is that even for those with already presenting cognitive changes, dementia, various stages, we are still seeing some benefit from management of hearing loss. But that benefit really does come when you meet the patient and the family where they are. For some people, that's a hearing aid. For other people, that might be a pocket talker. But what is more evidence is showing is that there's improvement in depression, anxiety, those kind of more negative dementia-related behaviors that can be really challenging for families and providers to kind of work through. There are some studies that are starting to show that some of those can be decreased as well with hearing intervention. So at the end of the day, it can really help at any age. What we don't yet know is, it's a little bit pathway specific, and that's where a lot of research can really help us kind of individualize and target what might be the best for people. But lots more research to come for that still. Yeah.
Another question I wanted to ask you is you hear a lot about dementia, like the Lancet study you mentioned, they talk about dementia. Yeah. And then other studies in other places, they talk about cognitive decline. Could you help us better understand the difference between those two?
Sure. Yeah, absolutely. It's nuanced and it's tricky, and there's no cut point across all of it. You can think about cognitive abilities for adults or really any age as kind of a continuum. They go from this normal cognitive abilities with age to dementia or more severe dementia, and anyone can fall kind of anywhere across that continuum. There are cognitive decline specifically then would be represented change in functioning from a person's prior ability. And that prior ability matters, all not starting at the same place. There are certain expectations of how a person might function based off of their age and education level. We expect some changes to happen with age, just as the brain is taxed over many years. There's a lot of health, environmental, all kinds of factors that can come with that. And so cognitive decline is kind of representing a change over time. Now that change can be, more minimal. It can be severe to like dementia, like I indicated. There's this phase kind of in between those that's called mild cognitive impairment. What that is kind of thinking about, someone's, it's a symptomatic phase of dementia. So various aspects of dementia can kind of, the pathological changes can be happening kind of quietly, where in the background, so to speak, where someone's not actually demonstrating any clinical presentation. But mild cognitive impairment is where they're demonstrating some brain changes. It's not exactly interfering with independence, but the family, the individual is noticing something different. Someone progresses to dementia where there's changes are substantial enough where it's interfering with their independence and their ability to kind of function day to day. All of this is determined, again, there's not a clear cut point. It's a complicated kind of determination that goes from, a physician's interview, neurocognitive tests, if it's available, some lab work or imaging. It's a kind of a compilation of information, and it's based off of expert opinion. There's a lot of some changes in particular, I said the imaging and the lab work, the biomarker related changes that are really starting to help us understand that underlying dimension, where it could be coming from, and how we kind of use that with the clinical presentation is one of the things that there's a lot of new work that's happening, and maybe one day what we can contribute in the hearing world might be able to kind of fit into that puzzle piece, but that's what we still don't know as well.
That's interesting. Well, I have more of an epidemiologic question for you. Yeah. And you see this a lot in the research about odds ratios. And I think in that paper, in that article from Frontiers in Aging Neuroscience, you talk about the odds for cognitive impairment, I think is 1.22, and the odds of dementia are 1.28. Yeah. So can you unpack that for us? I don't want to go too far into detail here, but given your expertise as a researcher, I think you might be able to inform clinicians on what these odds might mean.
Yeah. So an odds ratio, when we say odds in papers, most commonly, and I'm going to generalize here, but we're talking about an odds ratio. And so that means you could think about odds as like a likelihood. So your likelihood of having a given outcome, if you have hearing loss, for example, compared to those that don't have hearing loss. It's a point of comparison between the two. So one way that you can think about, like the Lancet Commission that I mentioned, had an odds ratio of 1.9 for hearing loss. So those who have hearing loss are 1.9 times more likely, for example, to develop dementia. You can also think about it as 90% more likely. That what you referenced is, I think I was referencing another study in the paper where it was 1.22 and 1.28. An odds ratio of 1 means you're not more likely, you're not less likely, there's no real difference. Anything above 1 indicates that you're more likely. So an odds ratio of 1.22 to 1.28 is not drastically different between the two, but it's suggesting a higher likelihood. To put it into perspective, we all are well aware of the association between smoking and lung cancer. That association has been referenced anywhere from, an odds of 15 to 30, a much larger scale than what we're talking about. But I don't want to downplay, our 1.2 or 1.9. So that's still important in the grand scheme of things. But it's talking about like how likely might you be, and comparison. The comparison point is always important in the statistical epi world. We always are interested in who are we comparing to. Mm-hmm. I don't know if that's helpful. So yeah, and the difference is, again, that cognitive impairment, I think is what I said, versus dementia. That's the specificity of impairment. Could be anything. It could be mild cognitive impairment, it could be dementia, versus that distinction is what those were kind of getting at. And all of that matters too when we're thinking about intervention.
No, that's a good explanation. Thank you. That helps, especially to get that frame of reference from smoking and lung cancer.
Yeah. That's one that we're all familiar with.
Right, exactly.
And is very established. Yeah.
Well, another thing
in that same paper, though, they reference the odds ratio for hypertension, which a lot of people are familiar with that being a risk factor for dementia and cognition, and that's at 1.6. So 1.9, where our likelihood from hearing loss, I say our, like, as a field, is greater than what is already being presented within hypertension, which I think is really interesting.
That is interesting. Well. Yeah, I didn't know. I didn't put the two together. Mm-hmm. That's good to know. I wanted to ask you another question that I think you'll be able to help our viewers with, and that is screening for cognitive function. That's a kind of a hot topic in the field right now.
Yeah.
What's your advice to clinicians around, should they add a cognitive screen to their clinical protocol? What are your thoughts on that?
Yeah, I'm torn. I think that there's a great opportunity for us to be included and potential for audiologists to kind of help support our fellow care providers of primary care, physicians, gerontologists, those that have the similar interest of the general health and well-being of our patients in mind. What I'm hesitant about is I don't feel like we currently have the right pathway set up for this to actually be beneficial for our patients. I'd want to make sure that right now there's kind of a limited dialogue between ourselves and these providers that actually we would do something about any screening that we have. So wanting to make sure that, one, we understand what a screener is, how to interpret a screener. There are many different types of screeners, that we have a direct connection and relationship with those like the primary care, the gerontologists, those who specialize in these types of things, neurologists, for example, and that we understand how to communicate the results and how to communicate to those other providers as well. If we do a screener and we get, a score that would indicate some level of cognitive impairment, well, what are we going to do about it? Is what I want to make sure that path is in place. There are some very well-known, validated screeners for general screeners for cognition. The Many Mental State Exam is one that's used commonly. The Montreal Cognitive Assessment, those are commonly used and have the potential that we could employ them. There's been some studies that are showing the fidelity and validity of their use in individuals with sensory loss too, which is important. We want to make sure whatever we're using, both within our population of those with hearing impairment, since most of those are in oral administration, is maintained. Same thing for those who are, for your geriatricians, we want to make sure that they're factoring in hearing loss, for example, when they're administering these assessments. So at the end of the day, thinking about also, what we can provide for those individuals beyond just a screener. The hearing loss, we're gaining our support, our evidence for that. As far as peripheral hearing loss, there's, like I mentioned before, there's a lot of interest thinking about, well, maybe we can use our speech and noise assessments, our central auditory performance as a way suggested to be a marker of cognitive performance. Some people have suggested it might be an early marker that we could maybe one day add to kind of these neurocognitive test batteries. I say add to in the sense of, combine them with the other information and not to stand alone. So I think there's a lot of potential there, and I'm excited for that potential. But I think what is primarily missing right now before we actually engage in that is that cross collaboration. Because us providing the screener without the next steps or the right communication doesn't really help our patients. It might confuse them or harm kind of what we're actually trying to do. And that's my concern.
Yeah, I share that concern. I think it's really difficult to know sometimes what to do with the information that you have.
Yeah.
Um, and I think as a profession, we haven't standardized that. And I think that's always a little bit of a problem when
Yeah.
it's not
Yeah.
standardized.
You know, exactly. If you look at the research that's out there, there's neuroscientists doing similar research that what our auditory scientists are doing, but they've stayed siloed. And I think that's part of the reason why we've been talking about this for decades, but we actually haven't really gotten a lot further in our progress of what we're doing about it. And so part of my goal is kind of bridging the gap between these two, to try to move us a little bit further forward and highlighting, well, this is what we know. What do we actually, what's going to help us move further faster, so to speak.
Next thing I wanted to ask you about, and we already kind of alluded to it earlier, and that is this relationship between intervening with hearing aids and, possibly slowing down cognitive decline. What does the latest research say? What's your take on all that research?
Yeah. So it's, the research that we have so far, we have some small trials that have gone on for a few months, a couple dozen, not a couple dozen, maybe 100 people or so, that are generally overall support the use of hearing aids to either delay cognitive change, or cognitive changes specifically. Most of the research that we have for hearing aids or cochlear implants, really, but especially hearing aids, what I alluded to earlier is the observational research. So it's thinking about, does this person already have hearing aids? Yes or no? What is their cognitive change over a period of time? There's a lot of power, there's a lot of strength in our observational studies because it tells us what we should focus on further. What we can't necessarily do is have a lot of control over all of these different factors, what we call confounders, for example, if you're unfamiliar with that, that can also kind of influence this association. The best way that we can do that is through a clinical trial, where we have direct control over who gets a hearing aid, who doesn't. Part of the concern of that is those who are more likely to have hearing aids are usually higher income, have better education, all of these other things that could be protective against cognitive change as well. So a clinical trial gives us a lot better confidence that we're really just looking at as best that we can through all of these various tools. How does that hearing aid influence changes? One of the longest and largest clinical trials for that, I'm putting in a little plug here because it's my colleagues are part of the reasons to do this, is the ACHIEVE clinical trial. That's in a larger group of people looking at cognitive change over 3 years, and those results should be out within the next year or two. And that's
Really?
going to be kind of soon, hopefully. That's going to be kind of the
Mhm.
strongest evidence that we can have of how does hearing aids influence cognitive change or dementia. A lot of what we have so far really is suggesting that. And again, same thing, the limited information we have on cochlear implants. I don't want to minimize that. It's just a smaller, both research-based and population that we're talking about. And so as far as kind of how that could influence, like I said before, it really depends on that pathway that we're talking about, whether it's a short-term change, a long-term change. There's a lot of potential different things that it could influence. It could influence social isolation, like I said, risk for depression, a lot of different things. And we talk about hearing aids, but there's also a lot of information about hearing management in general. So there's some more recent interest in, thinking about hearing devices in general, with the changes in policy coming up in the future. It's not going to be specific hearing aids. There's going to be other things that we have to factor into, including just general communication strategies. All of this are things that we need to kind of grow our evidence base if we want to kind of move things along
Right. I mean,
and care in general. Yeah.
simple, like just having a hearing aid and wearing it a couple hours a day, you're going to get the same results as if somebody wore them, all day long. So there's a lot of unknowns, which brings me to the last question that I want to ask you. And that is, given all your experience as a researcher, as a clinician, what's one big question that you'd like to try to answer in this area over the next few years with your research?
Yeah, well, my research, I think I've already alluded to the biggest questions that we need to answer. And one is, do hearing aids actually change cognition, like we just talked about? And two, how is this association actually happening? Those are two of the biggest things that are going to help us understand what we can do for like how we manage and treat our patients. there are other kind of more nuanced things that I think are important for our understanding and the strength of the evidence that we can present. And all of this evidence matters because it informs our clinical care and it informs our policymakers. Having strong kind of cohesive evidence can help maybe, get hearing aid coverage, get hearing services covered, that kind of thing. And right now, we don't know if hearing aids for sure do anything. We assume they do based off the evidence we have, but we need the strong evidence. We don't exactly know how it works. We have ideas. It could be multiple different ways that it works, but that's all going to matter as far as what we do with our patients. And then again, wanting to make sure that whatever we're doing is meeting the patients where they are, both as far as ensuring the testing that we're doing is valid and accurate still, and that we're working together to kind of provide that person or family-centered care that's really going to move things forward. And until we kind of do that cross collaboration and talk with other professions and specialties, there's still going to be some gaps in what we're doing. So in my opinion, kind of those are the biggest areas that are needed to move us forward.
Well, we look forward to more work in this area from you and your team. And thank you for all of the valuable work that you've already done and contributed to the field. We appreciate it.
Yeah.
Speaking for all the clinicians out there that watch this.
Exactly. Yeah.
All right.
Yeah.
So Danielle Powell, epidemiologist, audiologist at Johns Hopkins University in Baltimore, School of Public Health. Thank you for your time. And I want to let the viewers know that a couple of her open access articles that we referenced here will be in the show notes, and you can look for those and click on the link and it'll take you to the open access article. So thanks again, Dr. Powell. We appreciate your time.
Yeah, thank you.